Take your seats so that we can get started as soon as possible.
Everybody without the necessary magic devices? Thank you. Right. Yes, Ms. Bottle.
Good afternoon, sir. This afternoon we will hear evidence from Dr. Haslam. May the witness be sworn.
I do solemnly, sincerely and truly declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Thank you, Doctor. Do sit down, please, because that's where the microphones are. They're not mainly amplifying, they're mainly just recording. So speak up and questions will come from over there.
Hello, Dr. Haslam.
Hello.
My name is Emily Pottle, and I'm asking questions on behalf of the inquiry this afternoon. Can I begin by asking for your full name, please?
My name is Dr. James Duncan Haslam.
Dr. Haslam, you have provided two statements, I believe. The first one is inquiry reference 004479, if that could be brought up, please. Dr. Haslam, that statement should be on the screen in front of you. Do you recognize that as a statement that you gave on the 9th of July of 2018.
I recognise that, yeah.
Okay. And if we can just turn to the last page.
You've got a hard copy with you, have you, Dr. Hassan? By all means, work from that if you want to.
Yes. So it's
Do
3
keep
pages.
your voice up if you would.
The statement is 3 pages. Do you see that?
Yeah,
Is that statement true to the best of your knowledge and belief?
yes it is.
You provided a second statement, which is inquiry reference 004409, which is pulled up on the screen now. It's dated the 16th of August of 2022. If we just turn to the last page, it's very short, in fact. Do you recognize that statement?
I do.
And is that statement true to the best of your knowledge and belief?
Yes it is.
Sir, may those statements be adduced into evidence?
Yes, they may.
Now, Dr. Haslam, those 2 statements you have in front of you, as the chair has said, you can refer to them at any point to assist you in your recollections.
Dr. Hassan, the rules are basically these. If you don't know the answer, say so. If you can't remember, say so. But if your witness statement helps you remember, by all means use it. Okay?
Yeah,
Doctor, you were the consultant responsible for the care of Sergei and Yulia Skripal from Monday the 5th of March 2018 and onwards. Is that right?
that's right. From the afternoon of that Monday until the Friday afternoon of that week. And then I looked after them for significant chunks after that as well. So the following, most of the following Monday to Friday and other sections in that time as well.
Did you have any involvement in the care of Dawn Sturgess and Charlie Rowley?
I wasn't directly involved in the care of Dawn Sturgess. I was briefly involved in the care of Charlie Rowley, but it was further on once he was recovering.
I see. So you had a small role when he was recovering from his poisoning.
Yeah.
Can I ask you, at the time that Yulia and Sergei Skripal were admitted to Salisbury District Hospital, so in March of 2018, what was your role at the time at the hospital?
My role then and now is I'm a consultant in anaesthesia and intensive care medicine.
And you were appointed to that post in August of 2015, is that right?
That's correct.
And so you remain in that post now?
I do.
Okay. I'd like to ask you now about Sergei and Yulia when they arrived at Salisbury District Hospital on the 4th of March. You were not on call that day,
No,
and so you weren't at the hospital.
no.
In making your statement for these proceedings, you consulted the patient's contemporaneous medical records. Is that right?
That's right.
Okay. So now I'd like to take you to page 2 of your first statement, paragraph 5, just to ask you about Sergei Skripal, his condition when he arrived at Salisbury District Hospital.
Mm-hmm.
So this must come from the records then, Dr. Haslam.
Yeah, I wasn't present on that Sunday, but I would have consulted the records and also spoken to colleagues who were present.
Right.
You've set out in your statement that when Sergei Skripal arrived at Salisbury District Hospital on Sunday the 4th of March, he presented with bilateral meiosis, and you've put in parentheses there, pinpoint pupils, and profoundly comatose, scoring 3 on the Glasgow Coma Scale. He therefore required intubation and mechanical ventilation, although he was still able to breathe at that point. It became apparent that he was developing cardiovascular compromise with bradycardia, which is a slow heart rate, and hypotension, which is low blood pressure. He developed hypothermia, which is a low core body temperature, lacrimation, which is excess secretions and the flow of tears, diaphoresis, which is excessive sweating, salivation, oliguria, which is low urine output, acidosis, and apnea, which is an inability to draw breath. And you say, overall, the clinical picture was one of profound compromise of the central and peripheral nervous systems. Is that right?
That's correct.
Can you just help us with this? A score of 3 on the Glasgow Coma Scale, is that a low score?
It's the lowest score.
I see. And in layman's terms, what does the Glasgow Coma Scale show?
It's a measure of a patient's level of consciousness. A GCS of 15 would be alert, orientated, down to 3, deeply comatose.
So he had the lowest score, and that would mean that he was not responsive. Is
Indeed.
that right?
Yeah.
Okay. If we turn then to Julia Skripal, when she arrived at the hospital, it was the same day, the 4th of March. She arrived with her father. She presented also with bilateral meiosis, profoundly comatose, scoring 3 on the Glasgow Coma Scale. What does that say? Apneic?
Apneic, yeah.
And that means that she was unable to draw breath, is that right?
She wasn't breathing.
Wasn't breathing, I see. Requiring manual ventilation on arrival at the hospital to keep her alive, and was subsequently intubated and mechanically ventilated. She was profoundly hypothermic, fecally incontinent, and bradycardic. She developed lacrimation, diaphoresis, salivation, hypotension, and oliguria with worsening acidosis. Overall, the clinical picture was one of profound compromise of the central and peripheral nervous systems, and her condition was worse than that of her father. Is that right?
That's correct.
Okay. I'm just going to take you now to the contemporaneous medical records we have, first for Sergei and then on to Yulia. And they are inquiry reference 006126. If we can start with page 3. Dr. Haslam, this is the record from the emergency department, is that right?
Yes.
And this is the record for Sergei Skripal, is that right?
I believe so. Yeah, it says his name at the bottom left there.
Mm-hmm. And then we have...
I'm so sorry to interrupt, Ms. Bottle. If it's the emergency department, is this on admission or is this subsequently?
This would have been on our arrival into the A&E department.
Right.
And if we look at the bottom of the document here, the last box, it says clinical notes. Can you just translate for us in layman's terms what is recorded when Sergei arrived at the hospital? So
that symbol means male, brought in by ambulance to emergency department as found unresponsive by...
Oh, sorry, Dr. Haslam, I should have said. We need to take things slowly because a record is being created of what you said. And of course, it's natural when you're reading something, I can tell you, to do it more quickly. But I'd ask you just to take things slowly so we can have a record.
Sure. Shall I start again?
Please.
Male, brought in by ambulance to emergency department as found unresponsive by passers-by. GCS, Glasgow Coma Scale, 3 out of 15. Given naloxone, 2,000 micrograms. Given IV intravenously. Patient very agitated. Given intravenous 10 milligrams diazepam given. On arrival to emergency department, A for airway, right nasopharyngeal airway in situ, trismus present.
Is that with the jaws clenched?
Yeah.
Is that right? Okay. And just before you continue, we heard from Dr. Ord yesterday that this A, B, C, D assessment is a standardized assessment performed of the airway, the breathing, the circulation. Is that your understanding?
That's correct, yeah.
Okay. Please continue.
B, breathing, respiratory rate 14, SATs, oxygen saturations 100%, and that's on 15 litres of oxygen. That's an image of the drawing of the lungs with reduced air entry on the left base.
Is 14, is that a low respiratory rate?
That's
or
a
high?
normal respiratory rate.
It's what?
A normal respiratory rate.
Normal assisted, as it were, or normal?
No, he's breathing for himself.
He's breathing for himself.
Yeah.
He was breathing for himself at that stage.
Mm-hmm.
Normal respiratory rate. His saturation was 100, which is the maximum.
It
that
is,
right?
but that's also on supplemental oxygen.
Yes.
Yeah.
Okay. Now, if we continue, well, in fact, we go back to page 2, the record continues. So here we have C, which I suppose is circulation.
Yeah. Are we able to zoom in a bit more? Is that possible? That's great, thank you. So C circulation, heart rate 88, blood pressure 158/94, capillary refill time less than 2 seconds. Peripheral pulses, I assume that means present bilaterally. D,
Sorry, if I can just pause you there. So on C, are these sort of normal measurements for circulation?
heart rate's normal, blood pressure's a little high. May have been hypertensive. I think he was a hypertensive, so that may have been normal for him, but it's a little high.
Okay. If we continue then.
D for disability, warm. I think that means it says. Oh no, that's. I'm not sure what that word is. BM 14.8. So that's a blood sugar 14.8, which is higher than normal. GCS, Glasgow Coma Scorer Scale, is 3 out of 15. Pupils are pinpoint. Abdomen soft, non-tender. MSK, I think that means musculoskeletal. No something noted. I assume that means relatively normal in terms of a kind of a trauma assessment. Yeah.
Injury, possibly?
Sorry, yes, no injury noted. That's right, yeah.
And then if we move on down the page to the plan,
Mm-hmm.
and I suppose that's the doctor making the notes in the emergency department. This is their plan for the management of the patient. Is that right?
That's right.
And it says, I think ECG. Is that correct?
That's right. Electrocardiogram.
What would that tell us?
That will be a 12-lead ECG, so a formal ECG recording of the electrical activity of the heart.
I see.
Ticked, and N there means normal. QT interval, normal QT interval. So that's one of the measures we measure on there. Mm-hmm. Normal sinus-rhythm, nil acute. Then if you go to the right, that's a transcribing of an arterial blood gas. Do you want me to go through that?
What does that tell us, blood gases?
So basically, an arterial blood gas is a blood sample taken from an artery, processed through a machine, and it got a lot of information that we're able to use to assess how sick a patient is.
I see.
It tells you acid base, tells you about gas exchange, it tells you electrolytes, it tells you all kinds of things. Yeah.
Okay. And what do the results here tell us about Sergei's condition?
So pH is 7.3, which is slightly low. So it's slightly acidemic. PO2 is a measure of oxygenation, 31.8, which is high, but he's on supplemental oxygen, that's to be expected. PCO2 is 5.37, that's normal.
And the pH, if that, I think you said is slightly, is it
Slightly acidemic.
acidemic? What does that tell us about his overall?
You haven't got a complete blood gas there, so it's telling me the blood is slightly acidic, but I can't tell you more without the rest of the blood gas, which would be somewhere probably in the notes, but it'll be printed.
Okay.
Yeah.
And then if we turn to the plan, so they have ordered an ECG, and it seems that there's also blood tests to be ordered. Do you see that?
So the next thing's a chest X-ray. That's a box ready to be ticked once that's done. CTB is for a CT brain. Someone coming in unconscious would require CT imaging of their brain. Bloods, including CK, which is creatinine kinase. IVI would be intravenous infusion of fluids, intravenous fluids to be given. Then naloxone infusion.
That's a plan, is it?
This is part of the plan, yeah.
Yeah. And we've heard already from a few witnesses that the naloxone is used to try to counter the effects of an opiate. Is that right?
That's right.
So the plan here was to give a naloxone infusion.
Yeah.
And then I think it says the medical team discuss with toxicologist,
Yeah. So
consultant.
that would be a call to the National Poisons Information Service, which we can call for advice in cases where we suspect poisoning or drug overdoses, and for advice on how to manage patients. Yeah.
And the advice here was given for 2, I suppose it's micrograms of naloxone. Is that right?
It looks like that. So the consultant toxicologist for 2 milligram, it would be 2 milligrams. So you start with 400 micrograms, but to give a really test the response, you want to give more, so 2 milligrams of naloxone IV. And it says no reaction.
And then I'm interested here in the bottom right-hand corner. Do you recognize what that symbol is? Is that for diagnosis? Is that what that says?
I'm not entirely sure.
If you can't
it could be DG for diagnosis, but that wouldn't be a common symbol.
No.
But it's possible. Overdose, aspiration, pneumonia. I think that's basically the impression. Yeah.
Sorry, say that again.
It may well be diagnosis, DG. That we don't know. We know it could be a triangle. Sometimes we use a triangle for diagnosis.
Yes.
OD would stand for overdose.
Yes.
Aspiration, pneumonia would be another thing given the chest signs.
I see.
And then carrying on down to the left there, you've got intravenous coamoxiclav, which is an antibiotic, which sometimes given to make sure that the aspiration pneumonia doesn't become a worse infection. Then RSI is a rapid sequence induction, which I speak about being intubated and mechanically ventilated. So deeply unconscious patients are unable to protect their airway, and with someone with a GCS of 8 or less, we would tend to intubate and ventilate, and so that's what they did at 1840, and then a urinary catheter.
So for Sergei, when he arrived at the emergency department, he was able to draw breath and he had a normal rate, but he was eventually intubated at 1840.
He was. That would be for his conscious level.
Yes, I see. If we can leave Sergei for one moment and now turn to Yulia's record from her arrival at the hospital. Her record is 5544 inquiry reference. Yes, and if we just look at page 3, thank you. So we see here the notes say 33-year-old female, is that right? Found behind Tesco, unresponsive and profusely vomiting, with an older male in similar condition. On arrival, and here we have the ABCD assessment. A, eye gel in place, tolerates it well, I think I must say. And we heard already, Sir, I'm sure you recall from Dr. Ord yesterday, about the eye gel being put in place before Yulia arrived at the hospital.
Yes.
B, for breathing, symmetrical breath sounds, is that right?
Mm-hmm.
Respiratory rate controlled by, is that the bag valve mask?
That's
Is that
right.
D, for disability, C, for circulation, blood pressure 164/90. Is that a normal?
It's high.
It's high. Her heart rate is 42,
It's low.
and the CRT,
Capillary refill time is a measure of peripheral perfusion.
I see, 3 to 4 seconds.
It's prolonged, so she had poor peripheral perfusion.
Poor,
Peripheral perfusion.
meaning?
Meaning it would suggest her cardiac output isn't adequate to provide good perfusion to her peripheries. So what we might call it a shut down circulation.
Thank you.
So she didn't have as much blood flowing in her extremities as you would expect?
Yeah.
Is that fair to say?
Yeah.
And for D, disability, here we have again the Glasgow Coma Scale, 3 out of 15, the lowest score.
Mm-hmm.
And can you help us with what comes after? It says 2...
That's likely to be an assessment of her pupil response. So both pupils are 2 millimeters unreactive, which is meiosis, so pinpoint pupils unreactive.
I see. And if we turn over the page, so we're continuing this assessment with E. What does E stand for?
Exposure.
Exposure. I see.
So patients cold to touch, no needle marks, no open wounds, fecal incontinence. IO is intraosseous access in left tibia. You heard about that earlier this morning. And then I'm not exactly sure what that says, but it's 400 mics of naloxone from crew, no effect. Should I carry on?
Pardon me?
Shall I carry on?
Yes, please.
Yeah. So then 1 milligram of atropine IV led to a heart rate of 140 per minute, so jumped from 42 to 140. So atropine, we may come to talk about this, is an anticholinergic drug which can help increase your heart rate.
I see. And so for her, it went from low to, is 140 normal or?
It's high, yeah. Then rapid sequence induction with an endotracheal tube inserted, then an arterial line and a uric catheter, triangle diagnosis, query, OD overdose. Plan, CT head to rule out bleed, bloods, review, and then toxicology consultant suggested max dose intravenous naloxone. I think they mean 2 milligrams rather than 2 grams.
2 grams is too much.
Yeah.
Okay.
I'm sorry to ask you to go back, Dr. Haslam, but I think one or other of the words may not have got onto the transcript. Can you go back to the rapid sequence induction?
Yeah.
You added, I think, that a tube had been...
Endotracheal tube.
A which tube?
Endotracheal.
Endotracheal. Thank you.
So that's how we secure an airway to be able to put a patient on a ventilator.
So that's all that is. Thank you.
So as with Sergei, control was taken of her breathing. She was intubated.
She was.
Yeah.
And her rationale would have been that she wasn't breathing for herself and she was also deeply unconscious.
I see. I'd like to return now to your statement at paragraph 7. You said that following their arrival, in order to keep them both alive, it was essential to provide invasive, aggressive, and intensive medical life support, without which they would have died, as they were unable to breathe unaided and were suffering from multiple organ dysfunction.
Mm-hmm.
In a little more detail, the medical support that was provided, we know now they were breathing with a ventilator after they were at the emergency department. When you talk about intensive medical life support, what other support was being given at that stage?
There's another slide in one of the other artifacts that might be helpful to take through if that would make sense.
Okay, we'll take you to those slides a little later on, and I'll ask you then about the aggressive life support.
Yeah.
Okay. Now then, you took over the care of Sergei and Yulia Skripal on the 5th of March, Monday.
Mm-hmm.
Is that right?
Yeah.
Before we discuss your treatment of the Skripals, so that we can understand, you worked a pattern so that on the Monday you came on duty on call, is that right?
Yeah.
And you were on call until the Friday, is that right?
Yes.
And prior to the Monday, it was your colleague Stephen Cockcroft who was on call at that time.
Yes.
My understanding is that the usual pattern is that there's one of your specialty who's on call in the intensive care unit at a time. But over the course of this incident, you eventually came only to care for Sergei and Yulia Skripal, while your colleague looked after the other patients in the intensive care unit.
And DS Nick Bailey as well,
Yes.
when he came in. But yes, we had, I think it was on the Wednesday or the Thursday of that week, it was clear that it was unmanageable already for one person because of the nature of the major incident. So we ended up doubling up intensivists during the daytime. I cared for the major incident patients, and then a colleague, whoever was available that day, would care for the general ICU patients.
I see.
So that's all three of them, is it?
So I looked after those three patients from, I forget, the Wednesday or the Thursday. Mm-hmm. And then we kept that arrangement during weekday times for some time, some weeks.
So that you could really focus on this incident, which was quite challenging.
It was extremely challenging.
Okay, I'd like to take you back now to the clinical records. If we turn to Sergei Skripal's record, that's reference 6126. We go to page 11. This is a record we can see on the left-hand side, the 5th of March of 2018 at 3 o'clock. And it says, there's a sticker there, and it says ward round date. And I think written next to it is Cockcroft/Haslam.
That's right.
Would this be a record of the ward round that you conducted together with Dr. Cockcroft as a part of the handover between his duties finishing and you assuming responsibility?
That's correct. So it depends on the day and what the workload is like, but we will either do the morning intensivist will do a ward round, and then we might have a sit-down handover, or if they haven't had a chance to do a ward round, we'll do a ward round together where we hand over the patients at that time, which it looks like that's what we did that day.
Mm-hmm. On the right-hand margin, there's written, I think, is this your handwriting?
No, it would be one of our junior doctors documenting.
I see. I think on the right hand it says remains in bradycardia.
Yeah,
is that right?
I think that's right.
And then plan underneath this sticker. I think that's consult with toxicology. Is
It'll
that
be
right?
await toxicology.
CVC
Central venous catheter.
plus minus
Adrenaline.
So the plan would be to insert a central venous catheter so that you could administer and change the dose of adrenaline. Is that right?
I don't think we're looking at Sergei's here, are we? Is
yes,
that right?
that's right. Yes, that's right.
He hadn't had adrenaline started. You really need central access to be able to start adrenaline. So
I see.
Hence, plan would be to insert a central line so that we can start adrenaline.
I see. And adrenaline, what would that do?
It would give some circulatory support. If he's tending to bradycardia, which he was at this stage, it would help increase the heart rate and also increase the blood pressure.
I see. So we know that, he's remaining in bradycardia, so his heart rate is low. And so the adrenaline would help boost the heart rate, but also the pressure.
That's right.
Okay. And the entry underneath that, I think we've discussed it. It's not intelligible
I
to you.
can't read what that says. No, sorry.
Yeah. And underneath that, does that say atropine if heart rate less than
60.
60? Okay, so that was the plan, that if his heart rate was lower, despite, I suppose, the adrenaline, then the plan would be to administer atropine.
That's correct.
Okay. If we turn then to page 13, this is another entry on the same day, so the 5th of March, 10:15. It says night, I think that's review by Dr.
Nussbaum.
Nussbaum, and he's a colleague of yours, is that right?
He was a junior doctor or resident doctor, they're called, on the night shift.
Underneath that title, we see that triangle, which is diagnosis, is that right?
Mm-hmm.
It says poisoning question mark. I think that says substance, is that right? Or
Query substance, query organophosphate.
okay. At that stage, 10 o'clock in the evening on the 5th of March, had you consulted with Dr. Nussbaum about the possible diagnosis, do you think?
So I think at that handover round in the afternoon, I'd suspected possibly organophosphates. It no longer felt like an opioid poisoning or overdose. The symptoms had evolved over time, and it wasn't feeling like an opioid toxicity to me about that stage. And so, from the back of my memory, from studying for lots of exams, I wondered about organophosphates, and so I inquired about how to investigate for that. So I spoke with the National Poisons Information Service again.
Okay, if I can just pause you there, because you've given us a lot of information. When you say it wasn't looking like an opioid overdose anymore, what features made you think that it wasn't opioid related?
If we could go to that slide I mentioned, I'll explain. But that's the best way to do it.
Okay, well, let's see now.
Because that's the symptoms when I took handover.
Okay, so if we go to 4691. Oh, page number. Well, that's a good question. Let me just. Yeah, page 36. Is that right?
That's the correct one, yeah.
Oh, great. So this tells us, well, in fact, let's set this in context. This is a presentation which the slide says authored by FT49, who is a colleague at DSTL. What did you have any input in drafting this presentation?
Yeah, I wrote many of these slides, including this one.
I see. So this slide is entitled ICU Handover, Monday the 5th of March of 2018, and it tells us comatose, Glasgow scale, 3 to 15, and then gives a number of other conditions, which are, I think most of which are in the notes, but not all. So what from this slide made you think that it wasn't an opiate overdose?
So I think it was entirely reasonable to suspect an opioid overdose initially, depressed consciousness level, pinpoint pupils, respiratory depression. That's all characteristic of an opioid toxicity. Being unresponsive to naloxone isn't necessarily distinguishing. Some potent opioids wouldn't respond to naloxone, and so we tend to just give supportive care. So that was the initial period. over the next 24 hours. And when I came on, both patients had these symptoms. So
If I could just pause you there just to let the transcriber catch up. So when you came on,
both patients were still deeply comatose. They were being sedated, but still significantly depressed conscious level on sedation. Both patients were areflexic. So
what does that mean, areflexic?
So when you use a tendon hammer to elicit reflexes, it tells you that you have some muscle function. Both patients had zero reflexes.
And would you expect a patient, even one who was sedated, would they still have those reflexes?
They would normally, yes.
I see. So when you came on Monday and you saw that they were still deeply unconscious, didn't have those reflexes, is that what made you consider that it wasn't opioid?
There's more.
Please continue.
Yeah. So both patients were apneic. So although Sergei was initially able to breathe for himself and would have had assistance with a ventilator, by this stage he wasn't making any respiratory effort and had to be fully ventilated from the ventilator.
Okay, and would you, my understanding is from Dr. Ord that there would be some drugs administered when you intubate a patient to stop their reflexes from getting in the way.
Yes.
So a patient who is intubated in the emergency room, would you would still be able to tell, would you, if they were making their own breathing efforts?
So the drugs used to intubate a patient include a muscle relaxant, which would make a patient apneic, but they're short acting. They'd have worn off within about an hour.
I see.
And that was the day before. So these patients were still apneic, not making respiratory effort, despite pausing the ventilator and allowing them to breathe if they could.
I see. Anything else?
They still have bilateral meiosis. So again, that could be opioids, but it's also a feature of organophosphates. Both patients were having significant bradycardias and had intermittent dosing of drugs to treat those bradycardias over the course of the last 24 hours. And in opioid toxicity, that is possible but unusual. For the degree of bradycardias they were having, it was unusual. So again, that's another sort of alarm bell.
I see.
Both patients were hypotensive, low blood pressure, and needing support for their blood pressure. Escalating doses of drugs to support the blood pressure, again, a feature that would be unusual in opioid toxicity. Both patients were very cold, profoundly hypothermic, as in we couldn't record their temperature because it was that low, and that's despite active warming. So active warming, warm air blankets to try and warm the patients up. They were still profoundly cold.
And is that something that you would expect with somebody with opioid, an overdose, or no, not particularly?
No, that wouldn't be a feature of opioid toxicity. And patients in a hospital environment with blankets, etc., we wouldn't expect them to be cold. It's a feature of autonomic disturbance, which isn't...
Pardon me, just pause you there. It's a feature of what disturbance?
Autonomic.
Autonomic, okay. And what does that mean, autonomic?
So your nervous system is divided into your central and peripheral nervous system, and you have your somatic nervous system, which is, in kind of layman's terms, is to do with your the control of things that you have volitional control over, and then you have your autonomic nervous system, which is which your body controls automatically. And that's subdivided into your sympathetic and your parasympathetic nervous system. And these features, a lot of them are to do with the autonomic nervous system and it being dysfunctional.
I see.
Which, again, we can go on to talk about more, but is a feature of organophosphate poisoning and not necessarily a feature of opioid toxicity.
I see.
Sorry, what is it that's a feature of organophosphate poisoning?
So many of these features are areflexia.
Areflexia.
Yeah, apnea,
Apnea.
But to be honest, all of the things on this slide are features of organophosphate poisoning.
Taken separately or taken together? Or indeed both?
I'm not sure. Basically, this is, to my mind, was a toxidrome that didn't fit with opioids. It fit with something else, of which I suspected organophosphates.
Yeah.
It was not something that I'd ever treated before, and not many people in the UK have. Shall I talk about that a bit more?
Well, let me just, before we move on to that, finish. The other bullet points in the slide are lacrimation, which is increased secretions. Is that right?
So it's actually increased tearing.
I see.
Oops, sorry.
I see. I see.
So yeah, excessive tears.
Excessive tears, salivation. Well, I think we know what that is. Diaphoresis, which is the sweating.
Sweating.
Oliguria, which is the low urine output, and metabolic lactic acidosis. So that's, I think you were telling us before about the blood gases.
Yeah.
So these features, all of them, would be suggestive of organophosphate poisoning. Is that right?
Yes. I mean, I'll be honest, I didn't know all of those were features at the time. I knew that, I suspected the autonomic dysfunction was secondary to something other than opioids, of which I was wondering about organophosphates at this stage. Never having seen it before, only read it for an exam, I wasn't sure, but I wanted would try and get to the bottom of what toxin was at the root of both patients being very severely unwell.
I see. Would it be fair to say then, at that stage during the handover, looking at this constellation of factors, you thought it wasn't an opioid overdose, there was some other reason, you didn't know exactly what it was, you hadn't treated organophosphate poisoning before, for example, but you had come across it in your exams, I think you said, and it was something you wanted to investigate.
That's right.
Okay. Well, that's very helpful.
And that's at what stage, Dr. Haslam?
Monday afternoon.
Monday afternoon. And well, we needn't go back to it, but on one of the earlier slides, we saw a reference to, I think, Birmingham toxicology or something of the sort, for about 5 o'clock on the Monday afternoon.
That's when they would have been sent.
Does that make any sense or not?
Yeah, so that sounds about right for sending blood samples.
Yes, we will come on to
All right.
consideration of the slides in just a moment. But I'd just like to finish with the clinical records first, if I could.
Of course.
So we've dealt here with Sergei Skripal's clinical record. In fact, I'd like to just continue that. If we go back to 6126, and if we return to page 13, which I think is where we were, Dr. Nussbaum's entry. So he's mentioning poisoning, query substance, query organophosphate. So that is, no doubt you were in consultation with him, and you've explained to us that you were concerned that this wasn't an opioid overdose.
So I can't definitely remember exactly communication that happened on that day, but what tends to happen is that I would have had the junior doctors present that day would have we would have been communicating. They would have known that my suspicions, and I'd spoken to various individuals to get some advice.
Yeah.
So we're setting out feelers to try and get to a diagnosis.
And that's shared among your, as you would expect?
The team,
Yes,
yeah.
among
So,
the team.
so the day team would have handed over to the night team that this is a possible suspicion. And then that's what he's documenting there with his review in the night. I don't think I was present. I'd probably gone home an hour or two before this.
Yes.
Because I'm on for the whole week.
Of course.
So this is his assessment on the night shift.
I see.
But I would have been in telephone communication, but I was also researching myself at this stage.
Okay. If we turn the page to page 14, we see another entry on the 5th of March, 2245. It says microbiology Russell. That's Dr. Paul Russell. Is that right?
Yes.
And it says AWE, TRF radiological survey conducted. Is that right? Have I read that
Yeah,
correctly?
Atomic Weapons established, I'm not sure what TRF is, but it must be a team who can do the radiological survey, which, given that we were thinking of something exotic in terms of the toxic substance, that was one of the things that Paul wanted to exclude in terms of radiological poisoning, given previous espionage assassination attempts.
Yes. So you were considering whether it could be radiation poisoning, and the survey was face, hands, and I think, is that bedside surveyed?
For alpha, beta, and gamma radiation, nil found.
Nil found. Okay. Well, that concludes what we have for the records for Sergei. If we can move on to Yulia's records, so going back to 5544, page 16, please. Yes, we don't have to spend long on this part because we are going to hear from Dr. Cockcroft. But we can see here on the 4th of March of 2018, so that's before you take over, quite late, just before midnight, we see unclear history, potential poisoning, criminal proceedings, question mark, police involved and present at the ICU. So that, and you know, you might not be able to help us with this, but that suggests that at a very early stage, there was some concern by the treating clinicians that this wasn't a straightforward opioid overdose, but even at that quite early stage, that there was something else going on.
Yeah.
At page 19 of that record, we see this is where you take over on the 5th of March. It's a similar entry to the one we've seen for Sergei's record. The plan here also is to await toxicology. But if we turn to page 20, we can see an entry here, again, 5 p.m. on the 5th of March. There's a reference there to organophosphates. Do you see that?
Mm-hmm.
And can you just help us with this entry? It looks like it says med spike. What does that say right next to the date?
Medical SPR is a medical registrar.
I see.
One of our junior doctors or resident doctors.
I see. And he says Dr. Haslam, lorazepam prescription, is that right?
Stat, so straight away.
Ah, I see.
For query non-convulsive status. I had a suspicion she might be fitting at this stage, seizing. Secondary to possible organophosphates.
I see. Okay.
Sorry, Doctor, it's my fault. I'm not. Can you just read out for me again the line that begins, Dr. Haslam?
Yeah. Dr. Haslam, lorazepam 4 milligrams stat for query non-convulsive status secondary to organophosphates.
Thank you.
In your statement, and we don't need to pull it up right now, I can just read it out. At paragraph 8, you say that by the time you took over on the 5th of March, by that time our initial suspicion of an opiate overdose had been replaced with a working diagnosis of organophosphate poisoning, which was confirmed by tests revealing profound suppression of the activity of an enzyme called acetylcholine esterase.
Yes.
I think you've explained very fully, I think, why you came to that conclusion. Can I ask you, though, at that stage, after the handover on the 5th of March, aside from the clinical signs, which you've explained, did you have any other reasons to consider that there might be something more sinister going on?
So I was handed over the identity. We knew the names of the patients and also Sergei Skripal's professional background. Mm-hmm. And so at that stage, people involved with the incident had looked on the internet to find out about Sergei Skripal. And although there was a lot less about him on the internet back then, There was some information about his background, that he'd been a Russian spy with a spy swap, and so clearly there was it raised more suspicion about this being something, a targeted potential assassination attempt.
I see. I'd like to ask you now about the evidence of your colleague, Dr. Russell, who we've seen in the medical records. If we can pull up 5990, page 4, this is Dr. Russell's statement. Looking at paragraph 13, I'll just read it out. I then went to the ICU to discuss the patients with a duty consultant, Dr. Stephen Cockcroft. I raised the possibility that the patients could have been poisoned with a nerve agent, but at that stage he was convinced that the likely agent was a fentanyl-type agent. Do you recall in your discussions with Dr. Cockcroft, had he said that he thought it was fentanyl?
My recollection is that when we handed over on the Monday afternoon, that Dr. Cockcroft was under the impression that it was likely to be an exotic opioid substance, so something more like carfentanil, and that was what he was working his working diagnosis.
Okay.
Sorry, just a moment. Exotic opioid.
Yeah. So potentially not a drug of abuse per se, but an exotic opioid that might be used to assassinate someone.
Oh, I see. And what substance did you mention? You mentioned.
So my recollection is that he thought it might be carfentanil.
Carfentanil.
Yeah. So I think there was a terrorist incident in the past where that's been used.
Can you just spell for us is it just CAR, fentanyl?
I think so, yes.
I see. So it's another synthetic opiate, but it's not a drug of abuse.
Not typically.
Okay, I see. Turning then to paragraph 14, during the early afternoon, I carried out a radiological survey on the patients to rule out any radiation hazard. We've seen that in the notes. I found no suggestion of radioactive material and was later confirmed that night by a team from AWE Aldermaston. Paragraph 15, I went back to the ICU during the afternoon following the handover of duty consultants. The new consultant, Dr. James Haslam, was more convinced of the possibility that the patients had been subject to organophosphate poisoning. And then he advised the mainstay of treatment. And I suppose you would agree that you were more convinced of the possibility that it could be organophosphates for the reasons you've explained. Yeah.
It's important to state that symptoms were progressing over time, and what was initially the working diagnosis I don't think was unreasonable, and I think that's what probably opioid toxicity would have been the working diagnosis of pretty much everybody in the country. I think that would be my view, and so I don't think that was unreasonable.
You gave an interview to the BBC concerning your involvement in the response to the attack on the Skripals. Is that right?
I'm not sure if it was the BBC, but it was. I've conducted several interviews, but I'm not sure which one you're referring to. But it was an outlet.
An outlet. Yes. Sorry, I've said BBC because I think that's who eventually published it. But the program was entitled Secrets of the Salisbury Poisonings. The transcript, which we've obtained, is, if we could pull it up, inquiry reference 4178, page 7. And I just want to clarify. So we can see a transcript of your speech. Salisbury's fairly sleepy. Who'd have thought we had a spy living next door? And then you introduce yourself. I remember coming into work on the Monday morning. I was about to take over the ICU for the week. I'd heard that there had been 2 patients admitted the previous afternoon. There was an older gentleman and a younger lady. They were getting sicker and sicker. And then if we scroll down, yes, to page 8, thank you. At handover, the working diagnosis was opioid poisoning or toxicity, and I just, in my gut, I felt that wasn't quite right. They were severely critically ill, developing multi-organ failure. I thought at that stage this was likely to have been an assassination attempt, and then your mind starts spiraling as to what that means. I spent most of the night on the internet researching. And what I originally intended to ask you to clarify is the handover you're talking about, not the handover from the paramedics, but the handover from Dr. Cockcroft to your responsibility on the 5th. Okay. Thank you very much. I'm going to ask you now a bit about some further treatment. If we go back to your statement, reference 4479, paragraph 10. Sorry, paragraph 9, not 10, pardon me. Specialists at Public Health England and Defence Science and Technology Laboratory, that's DSTL, became involved after a major incident was formally declared. Following further tests, they advised us that the Skripals had been exposed to a nerve agent, which was later confirmed to be a Novichok. This information and further specialist advice enabled us to adjust and target our treatments. And we'll come on in a moment to the slides. But you provided a second statement, which is inquiry reference 4409. And at paragraph 5 of that further statement, you explain what you meant by that. You elaborated on what was meant by the further treatment and the antidote. Yes, so you say, as regards the specific antidote treatment, this involved the administration of atropine sulfate by continuous intravenous infusion, hyoscine hydrobromide by intermittent subcutaneous injection, and pralidoxime chloride by continuous intravenous infusion.
I think we need paragraph 6 on the screen, don't we?
Oh, pardon me. Yes, thank you, sir, that's right, paragraph 6. Yes, that's a summary of the specific antidote treatment. Now we can go to the slides prepared by you and your colleague. Inquiry reference 4691. If we begin at page 40, thank you very much. So here we have a reference to the clinical advisory group. So you mentioned that there were specialists that became involved, and I think they formed this clinical advisory group on the 6th of March. We can see you are the part of the internal team, along with Dr. Russell and Lorna Wilkinson. And the external team was Dr. Nick Gent from Public Health England, Professor Peter Blaine and Professor Simon Thomas from the Department of Health and also the National Poisons Information Service. There was also Dr. Boyd Gosh, a consultant neurologist, and FT49. And the ultimate patient decisions were made by the consultant intensivist, that's you, working collaboratively with these experts. Okay. And then the next slide, which I think, sir, you noticed when we first turned to this document, is page 41. It's a bit difficult to read, actually, but it's the entitled "The Birmingham Cholinesterase Results," which were reported on the Wednesday. So we can't actually see the results here. I think they're too difficult to work out. But can you help us? The results that were reported on Wednesday, the 7th of March, what did they show?
So I'm not an expert in interpreting these results, but we were able to phone the lab at Birmingham to help with interpreting these, but it basically confirmed our suspicions that there was severe poisoning with an anticholinesterase substance, so something suppressing the activity of the enzyme acetylcholinesterase.
Okay. And sir, we will hear from the experts next week about the mechanism of the acetylcholinesterase. So we don't need to go through that in detail now.
Right.
But you had those results on Wednesday, the 7th of March at 5. But we know you were already considering nerve agent treatment.
We were already, yes. So from the Monday afternoon, it was organophosphates were my working diagnosis.
Mm-hmm.
I also called the National Poisons Information Service at that stage on the Monday afternoon, who said to keep organophosphates in the differential, but they actually thought it was unlikely. And then I also spoke with our consultant biochemist because I wanted to know how to test for this. And so she recommended sending blood tests to Birmingham. But also in the meantime, the police had requested samples, blood samples, which had also been processed at DSTL. And so those results were phoned through on the Tuesday morning, I think around 7 a.m. to my night team.
Okay, if I can pause you there. And sir, we will hear from Dr. Cockcroft when he gives evidence about the police attending the hospital at an early stage the Sunday evening to get those blood tests.
Right.
And that those are the tests that blood samples, pardon me, and those are the samples that went off to DSTL as well and came back a bit earlier on the Tuesday morning.
Tuesday morning.
Okay. I'm just going to ask you about the specific treatment regimen very briefly. It's on page 42. So we can just zoom in there. It says the specific treatment regimen was developed from existing literature and advice from subject matter experts, anticholinergics, hyoscine and atropine, and oximes, and in this case, pralidoxime was given. Is that right?
That's correct.
That accords with your statement.
Do you want me to talk about the approach to treatment?
Yes, please.
So essentially in intensive care, we do general supportive care. So we support the physiology to try and maintain normal physiology with all the gamut of machines and drugs that we have at our disposal to do that. But then you want to try and treat any specific underlying pathology, and in this case, toxicology. And so essentially most of Monday night I spent researching about organophosphates and had learnt about nerve agents that night. So I was suspecting nerve agents by Monday night time.
Yes, you said.
So I'm sorry to interrupt, sir. I wonder if I could ask you to stop the feed, please.
Yes, stop the feed, please. take it the feed's restarted. Dr. Haslam, thank you for coming back. Could I just mention, you're familiar with most of these technical terms. Some of us, particularly the lawyers, or at least some of them, won't be. So if you could just try and enunciate them a bit more clearly and perhaps a little more slowly, it would help all of us, I suspect.
Okay.
Thank you very much indeed. Yes, Ms. Bottleton.
Yes. Dr. Haslam, I'm going to move on now from the presentation, the slides, and just to ask you a few questions about, firstly, the prospect of a discarded container of Novichok, and then a bit about the debrief meetings held afterwards. Following the attack on the Skripals, the authorities recognized the risk that Novichok may have been discarded, which would pose an ongoing risk to public safety. Were you warned of the risks that Novichok may have been discarded and that there existed an ongoing risk of future contamination to members of the public subsequent to the attack on the Skripals in March?
I think the whole of Salisbury was aware of that. My family and I live in Salisbury, as do most of my colleagues, our friends, and we all knew that there was a risk because big chunks of Salisbury were cordoned off and searches were taking place all across Salisbury hunting for it.
Okay. So you weren't informed by the authorities specifically, but it's something you felt was perhaps a common thinking at the time?
Yeah, yes.
Okay. In your in the interview that you conducted for the Secrets of Salisbury poisonings, I wonder if we could pull that up. It's reference 4178, page 28. You said, on discharging our last patient, there was a real sense of relief, of accomplishment. Things started to return to normal. All the fanfare of the press and everything had gone. In the back of our minds, there was a sense that the police hadn't found the Novichok, and so there was a niggling feeling. Could it still be out there? Do we need to be worried? And so here you're referring to your own inferences from a failure to find Novichok, that
Yes.
you yourself were worried.
I think not just Salisbury residents, but us in the medical community, we were worried that there would be more casualties. That was one of our early significant concerns because we wondered about whether we'd have the resources to be able to manage many more patients because it took a lot of manpower to care for these patients. And so we were concerned about that. And we were concerned that once we knew it was Novichok, that it hadn't been found, that was a risk.
I see.
So, and I think you said not just in Salisbury, but what did you add?
It's Salisbury the medical community and just residents in Salisbury.
Yes.
I think many people and businesses, and you will probably be aware that it had a very significant impact on all of those who live and work in Salisbury.
I see.
Right.
And just touching on the issues of capacity, you told us that after Dawn and Charlie had been poisoned, you weren't involved in Dawn's care, for example, and you were involved in the care of Charlie, but at a later stage when he was getting better. Was there an opportunity for you to pass on your clinical learning to the clinicians who are responsible for treating Dawn, Sturgess, and Charlie Rowley?
So, yes, there was. There was a formal clinical learning event hosted at Public Health England at the time, the Porting Down, not DSTL, Public Health England, and that was in late-ish April, where there was quite a significant clinical learning event which I attended. I forget now whether I presented at that, but I would have fed into that some of the clinical learning that we'd gathered.
Okay.
But there's as well as formal, there was lots of informal learning, and we're a very tight-knit team on the ICU at our hospital, and there was only 7 intensivists, quite a relatively small, wider staff, and all of us were involved with the care of these patients over the weeks that they were there.
If I can just pause you there. So you say there's 7 intensivists at the hospital. All of us were involved in the care. Do you mean you were all consulted in the care of Dawn and Charlie, or are you talking
No,
about
I'm
the
talking about
Skripal?
the Salisbury incident. So
Salisbury,
you're talking
yeah.
about the learning from Salisbury.
Yeah,
We were all involved with the care of the Salisbury incident patients
I see.
at various stages during their care and their time as inpatients. They were with us for many weeks. We'd all rotated through caring for them and were familiar with the treatment regimens, and we also discuss, I mean, this was a major topic of conversation, as you can imagine, for
Yes.
a long time. So there was lots of informal learning and discussion, and also we're all available to each other as a reference point for further information if any of us has any particular expertise. That's always the case.
I see. So there was only 7 of you in the intensive care unit, and you were in communication with each other, and you would share with each other the learning that you had, the understandings that you developed through treating the patients in
Yes.
the Salisbury attacks. Okay. So as well as sort of formal debriefings, there was informal communication among you, sharing your knowledge.
Yeah. There was even more formal learning and debriefing that happens subsequent to Amesbury, but it takes time to plan, and also the Skripals were still with us for many weeks, and we had to wait for them to recover to be able to then consent them for us to be able to disseminate wider their confidential patient information, and that process takes time.
Yeah. If I could just pause you there, because I'm going to take you through a series of 3 meetings, which we can discuss in just a little detail.
Sure.
So there was a meeting on the 19th of April. That's the Porton Down meeting you were telling us
At
about.
PHE, yeah.
Yeah, it was organized by PHE, and it was at Porton Down. So you attended, is that right?
Yes.
Okay. And do you recall whether Dr. Cockcroft was present?
Yes, he
At
was
the
present at that meeting.
Okay. And do you recall whether he was prevented from speaking about his clinical experience in the care of the Skripals?
I'm not aware that he was prevented from speaking.
Okay. And are you not aware because you just don't remember, or you think that didn't happen?
I think I don't remember, but I think I would have remembered if he was prevented, and I don't think I do remember that. So yeah, that isn't in my recollection.
Okay.
But you'd be able to ask him.
Yeah. The second meeting I want to ask you about is there was a meeting at the Lecture Theatre in Salisbury Hospital, and that was on the 21st of June of 2018. Were you present at that meeting?
Yes.
Okay. And do you recall at that meeting whether Dr. Cockcroft was prevented from volunteering information about recognizing and treating Novichok poisoning?
I'm not sure I'll be able to say that. I don't remember.
You don't remember? Okay. And just for completeness, there was also a debriefing at DSTL in Porton Down
There was.
on the 12th of July. Is that right?
Yeah, I can't remember the date, but we had a very in-depth debriefing event at DSTL, and I've also presented our learning in lots of different medical forums all across the country.
Okay. And you spoke a moment ago about problems with patient confidentiality. So at an early stage, when the Skripals remained unable to consent, is it right that they weren't able to consent to their medical information being shared?
Not for some weeks.
Not for some weeks. And then when they were able to, did they consent to
They
their
did.
information being shared?
Yes.
And that allowed you to disseminate the learning more widely?
To a medical community, yes.
To the medical community, okay. I see. And can I just ask, some of the slides that we looked at, they have a marking on them, medical in confidence. Is that a marking that you had put on there or your colleague?
No, I'm not sure who put that on there. There's various different presentations that were prepared. This is the DSTL version of those slides, which will have some of their markings on it.
Okay. But you can't help us with how
Essentially,
that got there.
I consented the Skripals and DS Nick Bailey to be able to disseminate the learning that we had, which would include some of their confidential medical information. But we would do our best to keep it at arm's length in terms of anonymising it. And clearly these patients are very identifiable. So that was the kind of the intention, is that we would present it to medical and UK agencies for learning, to be able to help teach people if this were to ever happen again.
I see.
But clearly this was a very, it was on front of newspapers for many weeks, and people would be able to identify who we're talking about.
Yes. The last thing I'd like to ask you about, just very briefly, is about the sedation hold. Your colleague, Dr. Cockcroft, in his second statement, we don't have to pull it up now, but sir, for your reference, it's inquiry number 5937, page 1.
Yep.
Dr. Cockcroft explains that you had ordered a sedation hold for Yulia on Thursday, the 8th of March, which is a routine practice, he says. Is that correct?
That's correct.
And I think you told us earlier this afternoon that it is done in order for you to assess, it's a normal practice for you to stop the sedation to see their neurological function. Is that right? That's
a standard, almost daily part of intensive care practice, yes.
Okay. And Dr. Cockcroft says that you had ordered the sedation hold, but that you weren't present when Yulia Skripal regained consciousness. Is that right?
I wasn't present in the room, but I was present on the intensive care unit, but just around the corner in an office. And it wouldn't be routine practice for me to be there, to be present at the bedside on a sedation hold. The nursing staff are present there 24/7, and they're kind of in a supervisory role, which might not be directly at the bedside.
Yes.
And that would be normal practice.
Okay, I see. Well, thank you very much. Dr. Haslam, I don't have any more questions for you, but if you wait there will be some.
Thank you. Mansfield.
Yes. I have a few,
Yes.
please. Good afternoon.
Good afternoon.
My name is Michael Mansfield. I represent the family of Dawn Sturgess. May I make clear straight away what the theme of some of the questions I want to ask? It's all one theme, really. And that is that the preparedness of the medical profession, whether they're on the front line or in the hospital, by the time of the incident and fatal event with regard to Dawn at the end of June. That's what I want to ask about. Now, first of all, after the, I'm going to call it the Skripal event, after the Skripal event in which you were involved, did you at that stage recognise the fact that there might be more Novichok, or did that come later?
I can't remember exactly when that occurred to me that there might be more substance, but I think it was a general worry from very early on.
From early on.
Yeah.
Yes. And the worry at your end was obviously being prepared to deal with it. You've already talked about resources. One of the important aspects, do you agree, about what had happened in the Skripal event was the risk that, I'll deal with them in two groups, the frontline workers may mistake what they see. In other words, the confusion between thinking it might be opiate of some kind as opposed to a nerve agent. Mm-hmm. Now, that was the risk that was recognised?
I think it's important to say that I don't think it was my responsibility to educate the wider...
No, I'm not suggesting.
Yeah. I think, in essence, when you have a casualty, you and I'm not a pre-hospital expert. I work in intensive care, so in a hospital with more resources available to me to be able to diagnose and treat. But in the pre-hospital environment, the important thing is to protect the staff and the public, and also to manage the patient and treat the physiology and get them to definitive care. So ultimately, the diagnosis, although it's important and may in fact affect the treatment that's given early on, as long as you're supporting the physiology and trying to keep the patient stable,
yes,
that can be addressed later.
Yes, I appreciate that, but you recognise, do you, and I suggest at the time, you recognised that there was a risk which could influence the whole course of treatment and handling within, from ambulance through to the operating theatre. Is that right?
There's a risk of misdiagnosing.
Yes.
I think there is, but that's kind of inherent to the nature of these pathologies. They are overlapping in the symptomatology, and it can be very difficult to discern that.
So that difficulty having been discerned, you would want to prepare. You won't have responsibility for the whole of the profession.
No.
But each person has a responsibility in the area in which they practice.
Yes.
And your responsibility with that regard would be to ensure, as far as you could, that your fellow practitioners understood the risk of misdiagnosis. Mm-hmm. You appreciate that?
I do, and I took that very seriously, and
yes.
I spent a great deal of time preparing, gathering the information of the clinical learning, and then disseminating it, including many presentations all over the country and several articles.
How much of that
half a minute, Mr. Mansfield.
Sorry.
You spent a great deal of time doing what? Gathering and disseminating?
I spent many hours gathering the information that we'd learnt. I helped facilitate further learning with DSTL, and also disseminating to the wider medical, particularly the intensive care and anaesthetic community. So I and my colleagues have done talks all around the country, even internationally, and I've also published a couple of articles on our learning.
Yes, I'm dealing with a specific period, that is between the Skripals and the death of Dawn Sturgess.
Yeah.
Now, in that period, in other words, by the time of what happened in Amesbury, had there been an identification of the features, the signs and the symptoms of between the two situations, the opiate poisoning and the nerve agency?
So as we spoke about, there was a learning event at PHE at Porton Down, and that happened in the intervening period. And there were representatives from across different disciplines in the NHS there, including the pre-hospital community.
Yes. Is it not right that that wasn't actually published until the day after her death?
That may well be the case, but that wasn't in my hands. I helped present the learning.
So whose hands would it be in then, if it's not you?
I think that was in PHE's hands, which is now UKHSA.
Now, in relation to...
Wait a minute, that's publication.
Publication, yeah.
But was it delivered to an audience, this?
It was delivered to a wide audience of representatives from across different NHS organisations, including a number of ambulance trusts. You'll be able to see who... I think the document will probably have who was represented there.
So by the end of June, then, on what you're saying, those practitioners working alongside you would have a clear idea of the difference between, the possible difference and differentiation between opiate poisoning and nerve agent.
The colleagues I work closely with on the intensive care, who I had responsibility to share learning with, yes, they would have known that, yes. Oh, but even having said that, it's still difficult to diagnose.
I'm not suggesting it's easy. That's the reason there has to be very careful analysis. Do you agree? Because it's not easy.
Yes.
Right. Now, so far as the practitioners inside the hospital, leave aside the frontliners for a moment, but did you have meetings which included paramedics as well as hospital
I think we had
clinicians?
We heard testimony earlier that I think it was Ian Parsons said that he attended one of those learning events.
So that in relation to the meetings, Dr. Cockcroft may say when he comes that in fact he was deflected from speaking about presentation, treatment and so on. And he names another doctor who intervened and, as it were, interrupted what he was going to do. Have you any recollection of that being at the meeting to yourself?
I'm not aware that he was prevented from speaking. I'm aware of an incident that you will be talking with Dr. Cockcroft about, I assume tomorrow, around the sedation hold, which I think caused a little bit of it was controversial, and so. But I wasn't aware that he was prevented speaking. In fact, I know that he has spoken at various different events, presenting his learning. I know he's done that.
Well, I'll leave it for Dr. Cockcroft then. Now, just returning to the dissemination of information and distinguishing between the two, is there a distinctive feature? Is there what's being called a litmus test or an acid test for distinguishing between opiate poisoning and nerve agent?
Well, a definitive test is a blood sample that's processed in a very. There aren't many labs that can do that, but Birmingham is where the NHS sends their samples, and that's your diagnostic test to determine if an anticholinesterase agent is involved.
Just a minute. There is a definitive test.
So the blood samples that then get sent to the Birmingham toxicology lab will tell you that there is a potential for an anticholinesterase agent. There will need to be further testing to determine what that agent is, but that's a kind of confirmatory diagnosis. In order to have a kind of working diagnosis, then that's where knowing your toxidromes is important. And having an index of suspicion, and I think expecting frontline paramedics to know the nuances of that, I personally think that's unreasonable. I think that some of them did is remarkable in my view, and so.
Sorry, I don't. You want to finish?
No, it's fine. You can.
That's all right. So the position here is that it may be difficult and so on, but I want to ask you whether in the circumstances that happened in Salisbury, and as you've indicated, it was of great concern to business community and so on, the necessity to use systems that would discern opiate rather than a nerve agent, you have to be alert and alive to the need for urgency to do that, do you not?
I think you do, but again, I need to emphasise this is very difficult, and nerve agent poisoning, especially this was a transdermal means of these patients having the toxin. The onset of the symptoms is quite subtle and slower onset. And some of the key characteristics that you read in textbooks about bronchorrhea, bronchoconstriction. So bronchorrhea is profuse respiratory secretions, and bronchoconstriction is intense wheeze. These patients didn't have those. And so, as I say, this is really quite nuanced and difficult to just have a clinical index of suspicion.
I'd just ask you to reflect for a minute on the Scripples. The signs were not subtle at all, were they?
In retrospect, I think
at the time they were recovered from the bench, the signs were already fairly obvious, weren't they?
I think in retrospect, I think at the time, I don't cast any blame on anybody not recognising nerve agent poisoning at that stage.
I'm not suggesting blame, but even after Scripple, looking back on it, even if you didn't think at the time, you will have discerned after Scripple that what happened on the bench wasn't subtle and nuanced, and that people in future have to be ready for an onset that's very quick and very dramatic.
Now, just let's pause and take this in sequence.
Certainly.
Mr. Vanstone. The question which matters, as I understand it, Dr. Hassan, that you're being asked about, is whether, armed with the knowledge of what happened to the Scripples and all the research which went on afterwards, there are things which happened to them which anybody should be able to pick up afterwards if it happened again. Are there?
Possibly. And I think it's not clear-cut. And I think it's I think with an initial presentation, the first presentation of a patient with a transdermal application of a nerve agent, I'm not entirely sure that it is clear-cut. And I think common things are common, and frontline paramedics would expect that to be an opioid toxicity and overdose, in my view. That would be my assessment of that. Now, I don't work in the pre-hospital environment, but I wouldn't criticise any of my colleagues who would think that this presentation could be opioid toxicity. Common things are common, and uncommon things are uncommon. And even though this was nearby to Salisbury, there wasn't any causal link between Amesbury and Salisbury at that stage. We didn't know that there was any link. And so I think thinking that this was opioid toxicity, or maybe opiates cut with organophosphates, which occasionally can happen, I think that's not an unreasonable suspicion, and not jumping to nerve agent, I think it shouldn't be criticised, personally.
I'm not, if you've understood the questions, I'm not criticising, I'm asking you about whether learning was suitably established by the time of the end of June and the Amesbury incident.
I think there were attempts to disseminate learning.
Yes,
there were factors that made that difficult, and I've explained that the Scripples were in patients with us for some of the many. Sturgess Scripple was with us for, I think, a couple of months.
Yes.
After the early March, and we didn't approach to get his consent to disseminate all the specific details until he was much recovered, which was towards the end of his stay. So a lot of that time was taken up with treating him and getting him well. And then if you look at the amount of time to disseminate learning, there wasn't a great deal of time. And we didn't know if and when Amesbury would happen. We had no idea at that stage.
I can put it shortly. Once you know there's a risk that it could be, but you can't establish without the tests, it could be a nerve agent. Mm-hmm. You'd certainly got that far after Salisbury, hadn't you? It could be a nerve agent, and was a nerve agent.
What could be?
No, Mr. Mansford, I'm sorry, but what could be? You'll have to ask
Yes, I'm
a little
so sorry.
more carefully.
All right. Once Salisbury had happened, the medical profession in Salisbury must have recognised that there was a risk, not only of the confusion, but whilst there's a confusion, there is a need to follow through the one with a risk to the public.
As far as I'm aware, that responsibility was PHE's responsibility, which is now the UK HSA, Health Security Agency, I think it's called. And as I'm aware, they did have communications to a wide range of hospitals in the area with this is what to look out for nerve agent poisoning. That was disseminated to emergency departments all around the area. Now, I don't have access to that because I don't work in an emergency department, but I'm aware that that was disseminated.
I want to ask you a specific question about the way in which you may have an antidote to opiate poisoning,
Naloxone.
Yeah, naloxone. Now, dealing with that, you've indicated, and I think you're the first one to say it in this way, that whilst opiate poisoning was a reasonable, original diagnosis, the fact that somebody was unresponsive to naxolin doesn't mean that it isn't an opiate.
Yes.
Now, why do you say that?
Because I work in intensive care. I've treated many opiate overdoses. Not all of them respond to naloxone. And sometimes you try high dose naloxone, they still don't wake up and recover. They require intensive care. That's why they come to me.
How widely known is that?
Amongst the intensive care physicians, very widely known, because we've all done it. We've all cared for these patients.
You've all done it?
Yeah.
Were you aware that in terms of the male patient in Salisbury, he'd had at least 2 doses, possibly 3, before he ever reached the hospital? Were you aware of that?
It was documented that he'd had some naloxone. I think we went through the documentation. It said 400 mics of naloxone.
But would that amount of still mean that it's, even if there's no response to that, it still could be?
Absolutely.
Right. And is that information that would be available and given to paramedics?
Paramedics aren't required to diagnose patients. they are there to keep them alive and support their physiology until they get to definitive care in a hospital. And then that's our job to in the emergency department, that doctors there and doctors from other specialties, including my own, is our job to help get to a definitive diagnosis, and that takes time. And I wouldn't expect paramedics to necessarily. They should have an open mind and treat potential options, but I wouldn't expect them to get to a definitive diagnosis.
No, you might not expect it, but if it happens, it has to be considered.
I think there can be a breakdown in communication. You know, we've heard that there were the paramedics at the Amesbury incident who suspected nerve agent, and I think there was a breakdown in the communication of that being a suspicion. But you need to say that's just from my looking in from the outside, because I wasn't involved in that early stage. But my colleague, Dr. Jukes, was, and you'll be speaking to him.
And the most important feature that's come out of some of the meetings you've been to is the need for accurate clinical assessment from an early point. That's one of the recommendations, is it not?
Yes.
And a clinical assessment should not be determined by information that may have no medical consequence whatsoever. Do you agree?
Can you ask the question in another way?
Yes, the question is this. In other words, if a police officer comes along and says, I think it's drugs,
Yeah.
you have to be very careful about...
Absolutely. I think all clinicians keep an open mind, and that was one of my learning points, that when I disseminated learning, was that you've got to keep an open mind and know your toxidromes, so that you're not just reliant on what's been handed over to you. You take a fresh look at the patient and try and that's what I did. You know, that's what...
Yes.
what
No criticism of you at all. I've not suggested it. Thank you very much.
Thank you, Mr. Mansfield.
Yes, so that completes Dr. Haslam's testimony. We don't have any other live evidence to be heard today.
No, well, that's well predicted by the sound of this. Thank you very much. Dr. Haslam, thank you for coming. There aren't any other questions, which means that you don't need to stay, though you can listen elsewhere if you want to on any future occasion, of course.
Thank you very much.
Thank you for your help. 10 o'clock tomorrow morning? 10 o'clock tomorrow morning. We are resuming under the same arrangements tomorrow morning, are we not?
Yes, that's right.
So the administrative arrangements, in effect, no gadgets, applies tomorrow morning as it has this afternoon. Thank you.